My name is Dr. Katie Moore, and I am very happy to be here to present to you the very broad topic of mind, memory, and mood in Parkinson's disease. I'm one of the Movement Disorder Fellows at the University of Florida Movement Department Division, rather. And what that means is I am a fully trained neurologist who's doing additional training in movement disorders like Parkinson's disease, and I'm really happy to be here to try to cover this topic. So we've got a lot to cover. Get your seatbelts on. We're going to be talking about motor and non-motor symptoms. Dr. Chu did a wonderful job of describing what a lot of the motor symptoms are in Parkinson's disease. What we know is that non-motor symptoms are a huge part of what patients and family members deal with on a day-to-day basis.
I'm going to ask quite a bit.
We're going to cover mood and memory symptoms in that non-motor category. So first we'll be talking about cognitive changes. What changes can I expect? When will they happen? What will they look like? And what treatments are available for them? Next we'll be talking about psychosis. Gosh, what is psychosis? What does that mean? And what things can we do? And when should we be concerned enough to start treatment? So mood symptoms and treatment for that. This brings up the point about whether medications that I'm going to discuss are officially approved for Parkinson's disease or not. Most of the medications I'm going to be discussing are not specifically FDA approved for Parkinson's disease, but we use them. We have a lot of experience with them in other conditions. I will point out the one that is approved for Parkinson's disease. And I would like to say I have no disclosures, which means I'm paid by the state and nobody else. But you're welcome to come up to me afterwards if you want to pay me. I'm happy to add you to my disclosures for next year's talk. This is a wonderful graph that you can find from the Parkinson Foundation that demonstrates basically who has Parkinson's and where. And it's basically anywhere in the country that people live. So you're going to have more common to have Parkinson's disease in patients where in places where there are more people. So the great state of Florida, as well as the great state of North Carolina, where I am from, has a lot of patients with Parkinson's disease. In the state of Florida, there are over 64,000 people who have Parkinson's disease, and it's the fastest growing neurologic disease that we have at this point. So what that means is that we're all involved in this Parkinson's pandemic and we're in it together. So when we think about Parkinson's disease, the first things you think of are movement symptoms. So it's typically tremor, slowness, and stiffness. And what I'll tell you is that in medical school, we all learned this TRAP acronym. And this is the thing that every doctor you see, for whatever reason, has at least heard somewhere along the lines that the symptoms of Parkinson's disease are tremor at rest, is T. R stands for rigidity, which is stiffness. A is akinesia or bradykinesia, which is the fancy Greek word for slowness of movement. And then you've got postural instability for P, which is balance and standing up straight, that kind of thing. But even that doesn't describe all of the motor symptoms that you can have. So this picture sort of starts to do that. You have things like masked facial expression or poker face, decreased blink rate, stooped or leaning posture, you're not swinging your arm or leg well when you're walking, shuffling gait, and much like me, small illegible handwriting. But motor symptoms really are the tip of the iceberg. They're the thing that's most easy to see, but doesn't even cover half of the things that you're dealing with when you're dealing with Parkinson's disease. So many people tell us that the movement symptoms are not the big deal. It's all these non-motor things that I'm dealing with on a day-to-day basis, either as a patient with Parkinson's or a loved one or caregiver. So this is a non-complete list of some of the non-motor symptoms that patients have. And one of the things Dr. Espay emphasized today is that every person with Parkinson's disease is one person with Parkinson's disease. Every patient is different. Every patient has a different combination of symptoms and issues that we help you to deal with. And so just because this is the list doesn't mean that you will eventually get all of the things on this list. Okay? I want to be clear about that. But they're very diverse because Parkinson's affects the whole you. So loss of sense of smell, sleep problems, either being too sleepy or not sleeping well at all, constipation, urinary problems, sexual dysfunction like erectile dysfunction. You can have drooling or dry mouth, fatigue, pain and sensory differences. And then at the bottom here, you see a whole section that has to do with mood and cognition. So depression, anxiety, apathy. impulse control, which Dr. Chu mentioned before, is increased gambling or spending or changes in sexual practices. And then cognitive changes, dementia, hallucinations, and psychosis. So we're going to be focusing on these 4 topics today. But don't panic. Knowledge is power. The word doctor comes from the Latin docere, which means to teach. So here we are. We're going to learn about these symptoms today so that you can be educated, you can educate others, including your doctors, about how we can best help you. So let's start with cognitive changes in Parkinson's. Over time, many of us, and some of you in the room may have some slowness of thought. You may begin to notice a little bit of slowness of thinking, and that's very, potentially is noticeable for you, but tends to be fairly mild. And then as symptoms progress, we move into this area that we call mild cognitive impairment. And it's not until things are interfering with your life that we start to call something dementia. So from the less severe on the left to the more severe on the right. Now when we think about cognition, it's more than just memory. There's a lot of things that go into the way that you think. And we call these domains. The 5 domains that you see up here on the screen are the things that are typically involved when we think about cognitive changes in Parkinson's disease. So I'm going to go through each one of those. More commonly, we see the 3 at the top. So we'll think mostly about attention and working memory, executive function, and visual spatial functioning. But you can also see differences in memory and language as well. So first off, attention and working memory. Calvin here, from Calvin and Hobbes, is well known for having poor attention. But you may find that you have difficulty focusing and paying attention to conversations or other activities. And this involves difficulty with working memory. So working memory is a particular kind of memory that you use when you're writing a list, when you're doing a math problem, if that is what you're doing. And so it means keeping in mind where I started, what I need to do with it, and how I'm processing that information. So that's working memory. And you might find difficulty with those types of things, so attention and concentration, and juggling multiple things at the same time in your working memory. Well, what about executive dysfunction? This is particularly important when we talk about multitasking, organizing and planning, getting through the day, and can affect employment issues quite a bit. Difficulty switching between focus and tasks. And then importantly for us, decreased initiation of activity. We'll talk about apathy later on in the talk, where it's motivation, initiation of things that you want to do. This is particularly important for me as a neurologist when I'm asking you to exercise, take your medicine on time, and come to clinic. It can be hard to initiate those things. Visual spatial changes are also really important. So if you're like me and you rely on Google Maps for absolutely everything to get from one place to another, this may not be such a change, but you may find that you have a decreased sense of direction, getting lost in familiar places, or have difficulty navigating new places. The visual spatial part can become important if you find you are bumping into walls more, having less sense of where I am in space, where my coffee cup is in space, and importantly, where my car is in space. So if you're finding that you're bumping into mailboxes and having near swiping kind of events, it can be valuable to speak to an occupational therapist about a driving evaluation and consider how you can be driving safely. Memory is a big domain. When we think about cognition, memory is super, super important. And I want to be clear about the kinds of memory changes that we typically see in Parkinson's. So we've talked about working memory being affected, but in Parkinson's disease, we tend to see more of a change in short-term memory than we do in long-term memory. And it's important to recognize that in long-term memory is who you are, where you grew up, who's your spouse, your children, those important facts about your life, but you may not remember what you had for breakfast this morning. And so the short-term memory is the things that are happening on in your life. Working memory is very, very short. Short-term is slightly longer than that, and long-term is more those fundamental facts about you. And finally, language is the fifth domain that we see changes in terms of cognition in Parkinson's disease. the thing that we typically see is that, gosh, if I could just find the right word, right? So we do see this tip of the tongue phenomenon, and doing brain training can be helpful for this. So before I even think about medication, if you're having mild slowness of thought, you're having mild cognitive impairment, there's a whole bunch of things that we can do to help your thinking and cognition. First of all, we want to make sure that we're excluding other causes. There's a number of things that can make someone look like they have cognitive impairment or dementia, and especially if this is happening out of the blue totally quickly, you're noticing a big change. We want to check for things like urinary tract infection, blood changes, those kinds of things like pneumonia or the flu that can make you not be thinking as well. So we want to make sure we're not missing that, right? Then what am I doing to you? What are your medications that are affecting your thinking and your ability to process things? So medications that are sedating, meaning making you sleepy, can make big changes in your ability to think. And then having a structured familiar environment, brain training, puzzles, that kind of thing, and importantly, exercise. Exercise is not just good for the neck down body, it's good for the neck up body. Exercise is great for your brain. So what is dementia? This is a slide that just tells us what generic dementia, not necessarily dementia in Parkinson's is. Dementia is caused by a whole host of things, and it involves these three factors. It's progressive decline in thinking or behavior in at least one of these areas. These are those domains of cognition we're talking about. And importantly, these changes interfere with your activities, day-to-day life and ability to function. So if I hear from you that, I'm not able to keep multitasking and things, and that's really impacting my life, that makes me start to think about getting in this dementia area. And I think the way this last part is worded, it says permanent change to the brain cells. That can seem really intimidating, but what that's saying there is, gosh, it's not from medicine and it's not from a UTI or something like that, but we can reverse. So as I mentioned, dementia, like this little picture here is saying, is an umbrella term that covers a whole bunch of different conditions. Dementia can occur in Parkinson's disease and usually is in the advanced stages of the disease. And one of this is, patients with Parkinson's are more likely than other folks to have dementia, but also, if you have the joy of living long enough, you can sometimes acquire different conditions as well. So we do see some patients that get other types of dementia. But how can we tell? So there's one thing, if you're telling me I'm having these problems, or my spouse or loved one is having these problems, it's starting to interfere with life, that rings that dementia bell. But it's important for us to try to understand what's your pattern of cognitive changes, what domains are affected and how much. So we can do short testing in the clinic, but may refer you also for more formal neuropsychiatric testing, which can take a few hours and gives us a lot of information. Parkinson's disease dementia, as I mentioned, affects the pattern of that. It's going to be more of attention, executive dysfunction, visual spatial dysfunction. That can also include features of behavioral changes, hallucinations, apathy, paranoia, and delusions, which we'll discuss in a little bit. Risk factors are listed here. Essentially, as you're older, you have more advanced disease, more progressed symptoms, you're more likely to have this, but not everyone will, as we mentioned. If you're someone who has cognitive changes at the beginning of your Parkinson's, that also puts you at higher risk. I know we've talked today about what are subtypes of Parkinson's and how do we as neurologists decide that you are this kind of Parkinson's, but there's a particular type of akinetic rigid, which just means you don't really have so much tremor, you just stiff and slow, and those folks are more likely to get cognitive changes. And then if you have hallucinations, that indicates to us that you may be at higher risk as well. So once we've gone through that whole pathway and thought about infections and other things we can do to help you with thinking, we can talk about adding a medication. I've listed a number of those here, including both the brand name and the generic names, in case you're familiar with one or the other. So to treat cognition, we can use Aricept or donepezil. There's Exelon, which is called rivastigmine, Razidine, which is galantamine, and Namenda, bementine. Try saying that 5 times fast. These medications don't work dramatically for everybody, but sometimes we see really good response. So it can be valuable to give that a try. Like any medications, there are side effects, some which we use to our benefit and some which we can work around. And so these particular medicines, like many, can cause GI upset in some people, wakefulness, slow heartbeat. So if I give something that keeps you awake in the morning instead of at night, for instance, that can be really helpful. So that's cognition. Let's talk about a related symptom, which is psychosis. So the major feature that we see is hallucination, and the definition of that is it's a false or distorted sensory experience that appears real, but it's not based on any external stimuli. It comes from within the brain. And these are things that can be felt, heard, seen, even tasted or smelled. Many patients with Parkinson's will develop hallucinations at some point, but it's typically later in the disease. And it's important that you let us know that you're having these, because not only is there something we can do to treat hallucinations, but also they can be due or worsened by our medications we're giving you. So it's really important that I know so that I can make appropriate changes to your medication regimen and help prevent these from happening. So I talked about basically any kind of sense that you have, sight, taste, smell, all those kinds of things, you can have a hallucination. But the most common types of hallucinations we see in Parkinson's disease, one is called a presence hallucination. That means you feel like someone's in the house or in the room with you and they're not. And visual hallucinations are common. These can be anything from shapes going by all the way up to, you see an animal or a person, they're in the room with you. So it's important for us when we're talking about hallucinations with you to decide if they are benign or not, meaning not really worrisome or not. So some people have described seeing naked ladies, but this is not bothersome to them. Some of us may find that frightening, and that's important to know too. So if they're bothersome, scary, disruptive, keeping you from getting good rest, those are things that I'd want to know about, because then I'd be more excited to treat them. It's also important for me to know if the person with Parkinson's has insight about their hallucinations. Meaning, do I recognize the naked lady is really not here or not? Other phenomena you may have heard about are illusions and delusions. They're slightly different than hallucinations, rather. And so I think since I get this question a lot, it's good to review what those are. Illusions, just think of you're seeing something that's there in the room, but your brain interprets it as something else. So hallucinations, there's no external stimuli, but with illusions, there are. So for instance, you may wake up first thing in the morning and think that your floor lamp is a person in the room with you. You may see that there are socks balled up in the corner, and your brain interprets that as maybe there's a mouse in the room. For this, sometimes it can be helpful to work on hearing and visual aids in terms of being able to improve the perception of what you're seeing. Delusions can be much more difficult to deal with. Delusions are defined as a fixed false belief or idea that cannot be reasoned with. So you can understand as a caregiver how these can be really difficult. So, we here have a cute one where the kitten thinks he's a lion when he's really not. But often what we'll see is the thought that someone is mismanaging or stealing my money from me. Spousal infidelity is one that we sometimes hear about, so you can imagine that becomes a real problem for folks and is part of this whole psychosis thing. So what's our treatment? Like many of the problems that come up with Parkinson's and really just in medical care overall, we want to make sure that I'm not doing it to you. So I want to make sure that the medications aren't making these symptoms come on and make adjustments where appropriate. We also have a number of treatment options that we can use when talking about hallucinations. They can also be helpful with some of those other things as well. These are all sort of antipsychotic, since this is a psychosis problem. So the most frequent one that you'll see is Seroquel or quetiapine. This medication works really well in low doses. It can cause sedation and weight gain. So we typically will give it at night. And sometimes weight gain is a bad side effect, and sometimes it's not. Sometimes we're trying to get a little weight on folks, so this can be very helpful. Nuplacid or pimavanserin is the one FDA-approved med for Parkinson's in particular that I told you I'd mentioned. Everything else is approved for other things by the FDA. And this medication works very well in addition. The thing to know is it can take weeks to work. So if you're coming in and saying, I'm having these nightly episodes of hallucinations. They're disruptive. They're causing problems at home. We might not choose this medication because I need it to work now, not a month from now. A third medication that we use that also works very well is called clozaril or clozapine. We tend to use this less often because it has a rare side effect of depleting the white blood cells in your body, and those are important for fighting off infection. This doesn't happen very often, but it can be really dramatic and life-threatening. And so when we use this medicine, we watch your blood really carefully. And so that if we start to see that change, we can go, whoa, let's stop the clozaril. But it can be a bit of an inconvenience. So initially, when you start this medicine, we check your blood every week. And so that means going to get your blood test and then picking out your prescription every week. And then over time, if things go well, we can spread that out. So that at the most you're checking your blood about once a month. But again, this medication does work very well. So let's talk about another motor symptom and talk about mood. So the most common things we see are depression, anxiety, and apathy. I'll help to define what those are and what we do. But these are very, very common. And you may have friends and family who have these conditions and don't have Parkinson's disease. But we know in Parkinson's disease that 80% or more can have significant problems with this. So I think it's helpful to use cartoon characters to explain complex issues like this. And if you're familiar with Winnie the Pooh, you know that a lot of his friends have been thought to maybe represent different conditions of mental health. And so Eeyore is thought to represent depression, even though he's a cute little donkey. He's got sadness and crying. He enjoys activities less than his friends. And people with depression not only have this, but can have appetite changes, one way or the other, eating a lot more or eating a lot less than they used to. Sleep problems, again, either way, sleeping a lot more or sleeping a lot less. Fatigue, a sense of guilt or worthlessness. And as I mentioned before, remember those reversible or treatable causes of cognition changes? Mood is one of those things. So depression and anxiety as well can cause difficulty with concentration, difficulty with speed of thinking. And then if some patients with depression do have suicidal thoughts, and that's something we want to get addressed right away. So if you or someone you love is experiencing suicidal thoughts, you want to reach out to somebody right away, and that can sometimes involve an emergency room visit. In terms of anxiety, that's going to be Piglet. He's a nervous little guy. He has generalized worry and thinks, what bad thing may happen to me at any time? He's got nervousness, tension, and fear. And these symptoms can lead to you avoiding activities, avoiding people, things that you used to love and enjoy, and can involve panic attacks, which can be really scary to experience. It can cause irritability and somatic symptoms. Somatic symptoms means I'm taking that nervous energy and it's turning into a headache or a stomachache or pain. I think we mentioned before in the last talk that anxiety is known to be a symptom of coming off medication. So when your levodopa is starting to wear off, you can experience some anxiety. That can be from the medication level changing itself, but also the, gosh, where's my med? Do I have water? Things like that. Is it going to work this time? Can add to a sense of anxiety. Apathy is a tricky one. So in picking a cartoon character, I think Garfield takes the hat. The only thing he gets excited about is lasagna and picking on Odie. Apathy can be a symptom of depression, and it is the lack of interest, enthusiasm, or motivation that we started to talk about a little bit before. But it can be occurring outside of depression. It can be just along by itself. And this, as you can imagine, can interfere with day-to-day activities. If you're not motivated to go see your grandkids, if you're not motivated to take your medicine, and for some people, if you're not motivated to get out of bed and shower and eat, those can be really significant problems on day-to-day care. And so it can really limit your enjoyment of life and also how well you are able to take care of your disease. So mood symptoms, in addition to the thinking and psychosis, can really impact how things are going for you and for your caregivers. So mood can impact your physical functioning, your thinking functioning, your cognition. It can affect how you take care of yourself and your quality of life, your relationships with family and others. It can affect healthcare costs, and then your physical and emotional health, as well as your employment. So please tell us if you're having these symptoms, there's things we can do. So I've listed here just a few of the medications. For mood medications, we're lucky to have a whole host of medications that can be helpful, safe, and effective in people with Parkinson's disease. I've listed the most common that we tend to use here. You may have heard of Zoloft, called sertraline, Celexa, which is citalopram, Lexapro, escitalopram, cousin as you might imagine to Celexa. There's Effexor, which is venlafaxine, Cymbalta, which is duloxetine. And these are medications that are given every day, and we tend to adjust the dose to get good benefit. This is something we sometimes have to wait for it to work, 4 to 6 weeks for some people. It's a slow process, but can be very effective. We just sometimes have to say, you know what, this one isn't working, let's switch to another, find the right one for you. There are also daily, as-needed medications that can be used. These are typically in the class of benzodiazepines, so you may have heard of Klonopin or clonazepam. There's Ativan, which is lorazepam, and Xanax, which is alprazolam. These basically differ in how quickly they work and how long they work. And we want to use caution with this particular class of medications because it can worsen your thinking, as we talked about, balance and fatigue. But they can be helpful if there's panic attacks or trying to bridge us to a new medication. Other really important things to consider, because I'm not all about medication. You may have picked up we're all about exercise. So exercise is a really big thing to support your mental health and help with mood symptoms. But it can be also helpful to meet with a psychiatrist. We as neurologists have training in psychiatry, but we do not claim to be psychiatrists, and sometimes we may want their input to really help us out with your symptoms and find the best medicine for you. It's important to know that psychotherapy or talk therapy can be incredibly helpful. It can be a little intimidating to think about doing that, but can be so helpful. And I think about medications and talk therapy as being better than the sum of their parts. So let's say medication is 2 and talk therapy is 2. You add them together and you get 6. So for those with working memory problems, that's not the right answer, right? That just means that both those together can really help. And so sometimes we'll recommend both of those things. And just to stay physically and socially active, if you're having apathy, making a schedule, sticking to that schedule, even if you don't feel like it, can really help. So sometimes I get this question, is my partner, is my loved one crazy? Are they lazy? No, you have mood symptoms, and those are things that we can help with. It's not something to be ashamed of. There's many people who have these problems, and if it's something I can help with, I definitely want to know about it. So reach out and tell us. We know that you don't have a choice. It's not like when you get on the airplane, they tell you have a choice to pick a certain airline. You don't have a choice when you pick Parkinson's disease, but we do have a choice about how we deal with it, how we approach it. So the good news, we talked about all these changes, these negative things that can happen with depression, anxiety, and apathy, is that when we get effective treatment, the decline in your Parkinson's disease from those symptoms can be reversed. So it's never too late to reach out. I want to point out some excellent resources that you may have seen on your way in today. These are some free booklets that are available for you today at the center and free for download online. This is just a small selection of the pamphlets that are available from the Parkinson Foundation, but if you're interested in more information, I strongly recommend these 3. To summarize, Parkinson's disease is common. It happens to a lot of people, a lot of families, and we're passionate about helping you and taking care of you. With that, we know there's a lot of non-motor symptoms, and these include cognition changes, which can occur over time, hallucinations, and dementia, which can develop as the disease progresses. But we want to look out for sudden changes. This is really important as you go home today. If you're seeing sudden changes in your ability to function, both from a motor and a non-motor perspective, it can be helpful to get checked out for any changes in infection or other problems medically that can bring those new acute symptoms on. And then it's important to remember that depression, anxiety, and apathy are super common in Parkinson's disease. When we think about cognitive, behavioral, and mood symptoms of Parkinson's disease, they can all worsen how you're doing on a day-to-day basis. But we can help, and if you take nothing away from this talk today, if you think you have some of these symptoms, if you think that might be going on, ask your neurologist. We want to help. Thank you very much for your attention. Questions? Yes, sir.
By any chance, do you have copies of your presentation to pass out?
So the presentations would be
Oh, right. These will be available on the center's YouTube channel.
On what?
The internet. I'm happy to say that too. You're not crazy. You're not crazy. That's a really good question. So the question in the back is, what do you do when you can't smell and you can't taste? I have some phenomenal dietitians at the center who help to adjust, for food things. So adding spice. Apparently this taste of sweet is the last thing that goes, so that's the most preserved taste. So you may find you're newly a fan of Ben & Jerry's. But adjusting your diet with a skilled dietitian like the ones we have at our center can be helpful to overcome that. I can't bring your sense of smell and sense of taste back, but the biggest thing that impacts is eating, and so those are the things that we can recommend for you. There was another question here, I'm sorry, in the middle. So let's start with the easy one. Let's start with driving, and how do you know when it's safe to drive and when it's not safe to drive? I'll tell you that neurologists are notoriously bad at being able to decide this. I don't know if that says something about our driving, but the best way to have this evaluated is to get a formal driving evaluation. It's typically done by occupational therapists. Many facilities will have sort of like a simulator, like a flight simulator, where you can drive, but in a safe way, and they can help you to understand if you're safe to drive. What's important to know is if you have one of these evaluations and they tell you you can't drive, you really can't drive, right? I mean, from a legal perspective. The other things to think about is if you're starting to have near misses, running into things that you didn't do before, it may be time to start thinking about retirement from driving. In terms of genetic testing for certain medications and how well you'll metabolize certain medications, that I'm not much for prognosticating in terms of how far things are in the future. There are certain medications outside of neurology that type of testing is done now, but it's not clear when that will be available for us. Okay, so the question in the back is about the best type and how much of exercise, what our prescription is, and I'll let you in on a little secret about the best exercise for Parkinson's. The best exercise for Parkinson's is the one you'll do. So the one you'll do and do safely. We understand that you have balance difficulty, and so getting on the exercise bike where your leg has to be higher than your head is probably not a good idea. But shooting for about 150 minutes a week, getting your heart rate up is good. It can be good to vary exercise, stretching, balance, aerobic exercise. It can be really helpful. I hope that answered your question. Fabulous. So she was sharing that on our YouTube channel, Sarah King has a talk about exercise and what best to do. So there's definitely some resources out there available, but find one that you love, that you will get up and do, and that's the right one for you.
Before I got Parkinson's, I didn't know what apathy meant. Now I don't care.
I think that's a good way to end the talk. Thank you guys so much for coming.
Thank you, Doctor.